Hey everybody, welcome to tonight's webinar on pathways that kind of affect clinical pathophysiology. My name is Michael. I'm a first-year neurology resident at UCSF. I've been with med school tutors for about 3 years now. I love teaching complicated pathways, especially in the webinar format. Tonight is extra special because I get to do it with one of my most cherished friends and smartest people I know, Leah Gober.
Hi guys, my name is Leah. I'm a fourth-year medical student at Mercer University School of Medicine. I've been with MST for about 1.5 years, almost 2 years now, and I am also really excited to be teaching with Michael. Fun fact, we went to med school together, and we have remained friends ever since. Michael got a little ahead of me, so he's a real doctor now. So here's a little bit about our agenda. We're going to talk to you guys a little bit about what MST is and what we do. Then we're going to sort of launch into these pathways. So the way this webinar was sort of born was Michael and I talking about how there are these pathways in medicine that we consistently teach to our students. And we feel like we're repeating ourselves a lot. And so we wanted to sort of reach out to you guys and sort of give this information to y'all in a way that was concise and a way that we felt sort of relayed a message and got you exposed to it sooner than maybe potentially you would otherwise, and maybe a better understanding at the same time. So we're going to talk about calcium, PTH, vitamin D, and the love triangle that ensues between them. We're going to talk about baroreceptor reflexes, the renin-angiotensin-aldosterone pathway, which is tested consistently, like high yield all the time. People love talking about it. And then shock and the chaos that reigns. And then at the end, we're going to have a live Q&A. So please stick around. During the live Q&A, you guys are welcome to ask us any questions across the board, anything you have, anything about the webinar, step 1, step 2, clinical years, all of it. So we hope to see you guys there. Michael, I think this is yours.
Oh, sorry. Great. So I'm just engrossed in what Leah is saying. So we're listening. Yeah, so we are at Med School Tutors. So offer tons of different services, like this webinar being just really one of them. One-on-one kind of online tutoring is really the cornerstone of what we do. So everywhere throughout the medical education continuum, so pre-med all the way through residency, so even through step 3, offer one-on-one, very personalized tutoring. So you heard Leah say that like what we're teaching today is born out of us individually teaching this probably dozens and dozens of times over to multiple different students. And the collective way that we found that it's the most successful way to kind of help people understand. We do that kind of on the shoulders of 14 years of other people within the company doing that. So there's lots of information sharing between the tutors. So working with MST is working with tutors who have been doing this for a long time and have learned from people who have been doing it from even longer. It's a very just wonderful collaborative environment between the students and the tutors. All of the tutors are med students, residents, attendings who absolutely love to teach, who want to be doing it and did well on their exams themselves, but kind of really are centered in this work and wanting to pay it forward and help people do that in the future.
All right, so I'm going to take the first question, which is on calcium homeostasis, and I just want to shout out to the participants. If you guys know the answer to some of the questions I'm asking, we really love y'all participating. It makes it more fun for us. It makes it more like enriching for you, so please do that. So our first case is going to be a 7-year-old girl. She's brought to the physician for failure to thrive. She's in the 5th percentile for weight and 8th for length. Genetic analysis shows a deletion on chromosome 7. That results in a misfolded protein. And she's got osteopenia with epiphyseal widening and metaphyseal cupping on physical exam, and I'm assuming imaging. So the question is asking us which of the following lab values is most likely found in this patient. And I know the arrows can be pretty daunting, right? Sometimes we see these questions and we're like, oh my goodness, arrows and a hard question, like how can we possibly get all of this right at the same time? Because this is really 4 questions in one, right? This is asking about 4 different things and how they change. What I want you guys to focus on when you see a question like this is pick what you know. And so if you know one of these columns, then spend time on that one and getting it right. Everyone's going to spend time on this question, right? Like across the board, all of us are going to spend time on it. You want to be the one that spends time on it and gets the question right. So think of the arrow questions as that, as like, I'm going to invest time into this and I'm going to get it right. So the thing that sticks out to me the most here is that we've got this osteopenia with epiphyseal widening and metaphyseal cupping. Can anyone tell me what that tells them? Does that sound familiar? Does it sort of link up with a vitamin deficiency we might know about? Low calcium, good. Vitamin D, awesome. So Elizabeth said vitamin D, and it's exactly right. This is a vitamin D deficiency. And rickets, yes, awesome. So this is rickets in a child, which is a result of a vitamin D deficiency. We don't necessarily have to know the background of why this patient is failure to thrive. We know she has a deletion on chromosome 7, there's a misfolded protein. If someone's a little bit scared of genetics or intimidated by it, you don't have to know that to get this question right. You need to recognize rickets and vitamin D deficiency. So from there, we're going to choose the column that coincides with vitamin D because we know it's low, right? So immediately, we're going to start with calcitriol, and we're going to say our answer is either A, B, C, or E, right? So we can get rid of D. Then we sort of want to trace through the next most obvious step in the pathway. So we know vitamin D is low, and if vitamin D is low, that means that our calcium is low. And we're going to learn a little bit more about this pathway in a minute and sort of walk through it. But because we know that calcium is low, we can actually get rid of nothing, right? Everything stays the same except for E. We can get rid of E, right? Good. Awesome. And as a result of low calcium, PTH is going to increase in response to that to try to increase the calcium and the vitamin D. So we're going to increase our PTH. And since PTH is increased, can anyone tell me what the mnemonic for PTH and phosphorus is, for remembering what PTH does to phosphorus? So it's phosphate. Yes, awesome. Nice, Michael. So it's phosphorus trashing hormone. So if PTH is high, often phosphorus is low. So someone said earlier, Suma, I believe it was, said A was the answer, and you are correct. You also asked phosphorus is low because decreased intestinal absorption of low vitamin D. And yes, that's correct. So the best part about these pathways is that, and also potentially the worst part, is that they all act on each other in multiple ways. So if we go on to the next slide, we're going to sort of talk about through the pathway and then also talk through different sort of methods or ways that I go through these and sort of holistically look at these questions. So the first thing you want to do is find the initiating factor or an answer choice that you know to be correct. So we knew vitamin D was low, right? And we sort of had to start with that. And so we had to know enough to know that that was rickets in a child vitamin D deficiency, or choose an answer choice that you know to be correct and then trace it backwards. So if you don't know that vitamin D is low, but you have a feeling this might be cystic fibrosis type thing, and you know other, hormones or anions, cations are low or high because of cystic fibrosis, then you can choose that and trace it backwards. I harp about using multiple methods of memorization because I think we're all different kinds of learners. And the truth is we don't really know what kind of learner until we try it out. And who's to say we're one type or another? So who's to say that you only draw pathways and that's how you learn? Why can't you draw some and write some out and act some out? So I encourage students to try multiple different methods of memorization. And I'm going to show you guys a few after we finish talking about this. And then the most important part, I think, of pathways in general is tying these concepts across organ systems and pathologies. So I put a few down here. Michael, I'd love if you have any input on any of these. But we know that this is a highly endocrine related topic, mostly in the context of parathyroid disorders. We also see it in granulomatous diseases. So can anybody tell me why we see calcium, PTH, vitamin D, differences in metabolism in a granulomatous disease? What about granulomas? Yes, awesome. 1-alpha hydroxylase, excellent. So macrophages secrete 1-alpha hydroxylase, and that's how we sort of tie all this in, which activates vitamin D. So we've got it in genetics. This patient actually had cystic fibrosis. So at the end of this, I want to go back and just read that question one more time so you guys see how the cystic fibrosis tied in. We see it in pancreatitis. We see it in kidney stones, CKD. A big one that I talk to students about a lot is hypercalcemia malignancy. We sort of forget that that exists, that that's actually a paraneoplastic syndrome that occurs in different cancers, squamous cell cancer, bladder cancer, ovarian cancer. They have a hypercalcemia malignancy as a paraneoplastic syndrome. And then, Michael, do you want to comment on any of these or how often you've seen them?
Oh man, so yeah, so much. I would say, right, I had a patient present with very severe hypercalcemia, and that was kind of it. So I think that we get maybe disillusioned as medical students when all the information is nicely packaged to us.
Yeah.
Patient present with a calcium of 16, which is astronomically high. And so unfortunately, when I went to go triage that patient's emergency room, my mindset was, where is this person's cancer? Not anything else. It was, where is this person's cancer? So I definitely think of cancer all the time with high calcium, thinking of low calcium, right? So maybe one thing that I would add here, so remembering that PTH release relies very heavily on magnesium, so the interaction between ions as well. So low levels of magnesium prevents the release of PTH, and so we can have hypocalcemia because of low mag. And I think other kind of, when we talk about CKD, right, so there's some intrinsic aspects of the kidney, but also the way phosphorus is handled by the kidney cause low calcium. So it gets a little overwhelming. And if you feel overwhelmed by all of the different ways that calcium can be affected, I would encourage you to just like kind of take one and learn it really well. And then a day or two later, do another. Don't sit down one day and be like, I'm going to master calcium today. There's too much.
Yes. Yeah. Awesome. So if we go to the next slide, this is sort of, I just wanted to show you guys, like Michael said, there are different ways of thinking about it. And each disease process and pathology affects a different organ system directly. And so it'll change the calcium homeostasis based on what it's affecting. So the big way to look at it is parathyroid hormone, because you're often going to be introduced to calcium homeostasis through parathyroid hormone. And then you've got its action on vitamin D and its action on calcium. I encourage you guys to reorganize this. So put vitamin D first and say, if vitamin D is low or high, how does that affect my calcium? How does that affect my PTH? So high vitamin D is going to encourage increased calcium, which is going to decrease parathyroid hormone. And then mix it up again. Put calcium first. Ask, if I have hypercalcemia malignancy, what happens to my PTH? What happens to my vitamin D? And this will sort of help you guys understand not only how they're all interconnected, but also why hypercalcemia malignancy causes decreased PTH. Because it's not directly because of the calcium, right? It's because we have PTHRP being secreted also. So there are two things happening there. And someone asked a question, Michael. Do you want to repeat that?
I'm typing it, but I also can.
Okay. Yeah.
It's a good question, and I think it gets very nitty gritty and like biochemical details. So magnesium is is part of the synthesis for PTH itself. So yes, chronically low magnesium will inhibit PTH formation. Also, magnesium is required for the end organ effect of PTH to be felt. So for two reasons, low mag can cause low PTH, or like this idea of low PTH. I think what you're referring to is that PTH being triggered by magnesium, inside the calcium sensing receptor, right? Normally vesicles of things are released in the setting of calcium, but in a calcium receptor that makes no sense. So the calcium sensing receptor uses magnesium to trigger vesicle release. So part of mag is inherently part of PTH release. It's very complicated. That's a great question. Hopefully that doesn't, but I would in my mind associate low magnesium with low calcium. And then the mechanism behind that is that PTH kind of requires magnesium, if that helps. I'll wait for you to, Suma, do you mind?
Sorry, I thought you were looking for my
Leah, does that make sense? Leah, is there anything that you have to, thank you. Awesome, great.
All right, so this is, again, I tell my students often, you have to be hungry for knowledge in order to find it sometimes, especially when you get into like a groove of, I know high PTH decreases calcium, you know, or increases calcium. All of these, like, once you get into a group, you really have to seek out knowledge. So reorganize things. When you look at calcium homeostasis, I want you to look at the different organs that it affects. Look at the bone. Ask what happens directly at the bone. You've got increased calcium and phosphate at the bone. Look at the intestine. Increased calcium and phosphate at the intestine. The kidney is different. The kidney increases calcium, but decreases phosphate. So it actually wastes phosphate in the serum. And then look at the parathyroid gland, same thing. So you really want to get creative. Be hungry. Be hungry to figure out how all of these things interact and how they're different and how they're similar. And this will come more naturally, and it'll be more of an innate drive the more you learn. But it's sort of just what I encourage students to do, is always try to look at it a little bit differently. So Michael, do you mind running back up to that question so we can read it one more time and talk about cystic fibrosis very briefly? All right. So you guys, we have this 7-year-old girl. She has failure to thrive. She's low weight, low length. She's not growing. And she has this deletion on chromosome 7 that results in a misfolded protein. The key here is not necessarily chromosome 7. I can't tell you how many times I've been tested on chromosome 7 and cystic fibrosis because I don't know that it's ever happened. However, I have been tested on cystic fibrosis and a misfolded protein. So that's huge. You really want to connect those two. And then you want to ask yourself, why is this? Yes, chromosome 7 is Williams syndrome. Awesome. So you want to ask yourself, why does this patient with cystic fibrosis have a vitamin D deficiency? And anybody sort of, awesome. Well, acute pancreatitis, yes. You do get brownie points for Williams syndrome. So what we've actually got is the pancreas is, so loss of fat-soluble vitamins because the pancreas isn't working. It's not necessarily pancreatitis, which insinuates inflammation of the pancreas. It is inflamed, but it's also dying, right? So we don't have a good pancreas in these patients. So they're unable to secrete pancreatic enzymes. They're unable to absorb fat-soluble vitamins. So A, D, E, and K are going to be low. Another way they can present these patients is going to be a coagulopathy, right? So vitamin K, you need it for clotting factors. These patients may not have a lot of vitamin K. They can present it as a vitamin A deficiency, right? So issues seeing at night specifically. These are things you want to think about and connect into calcium homeostasis once you get to that level. I do want to keep this simple for you guys, or as simple as we possibly can now that we've gotten like pretty complicated. But I hope this helps someone out there sort of understand the pathway better and link it all together, or at least encourage you to seek the knowledge and be really excited about finding out what you don't know. All right, Mike, it's all you.
Cool. I want to add one comment on this that I think that would just be, I would also, so we've talked about a couple big player hormones in calcium homeostasis, right? Parathyroid hormone being the big one. We've talked about parathyroid hormone related protein kind of peripherally about malignancy, and then vitamin D. Understanding that each of them has their own kind of unique interaction within the world of, so when we talk about effects that on bone, right, that tends to be really heavily predominated PTH. Like I know we think about vitamin D being good for bone health. Vitamin D is good for bone health because it brings calcium and phosphorus to the party for bones to use. PTH directly acts on the bone. If we talk about the intestine, PTH has very little direct effect on the intestine to promote the reabsorption of calcium and phosphate, whereas vitamin D has huge impact on the intestine to promote the absorption of both of these minerals. We talk about the kidney is inherently and very intimately involved in the production of vitamin D, right? Vitamin D has some effect on the kidney, right? On the proximal and distal tubule for both proximal tubule being phosphate, distal tubule being more calcium. PTH is the stronger driver at the level of the kidney, and the parathyroid gland kind of being the sensing hormone itself in the background. There are way more hormones that you could learn about calcium homeostasis, and this is to Leah's point, like this is not a deep dive, right? We talk about things like FGF23 and calcitonin and all the other things, right?
Rank L,
like there's lots and lots of ways. So I would just to make things a big picture, but I really love this graph and thinking about each organ system and what it can do to the calcium. So, all right, with malignancy, will PTHRB be elevated and PTH be normal? That's a good question. I would say I would actually almost expect the regular PTH to be suppressed, right? So in a negative feedback loop, if I have, let's say that I have a, you know what I mean, a lung cancer, a squamous cell carcinoma of my lung that's exogenously producing PTHRP in an unregulated fashion, my blood calcium level is going sky high. My own body is going to be like, why is your calcium so high? I don't need this much calcium, and is probably not going to produce as much PTH. So I would say normally, and this kind of works the same thing for like any endocrine, right? So when I think like exogenous production of cortisol or anything, if thyroid hormone, if I'm doing so much on the outside, my own body's probably not going to do it as much. So I would expect PTH to be low in a PTHRP mediated hypercalcemia. Leah, do you agree with that?
I do agree. And I was teaching a question the other day, and it was bladder cancer, and the PTH was low. So
cool. Okay. Now I'm going to talk about baroreceptors. And so we'll do the same thing. We'll lead in with a question. So a medical student is scrubbing into a carotid endarterectomy for a patient with recent transient ischemic attack. As the surgeon approaches the carotid sheath, she injects lidocaine just distal to the carotid bifurcation. The student correctly reasons that this action is meant to numb the nerve and decrease the patient's response to carotid sinus manipulation, therefore avoiding which interoperative event? All right, so this is a great example of a question that I would probably say is not just a simple first order question, right? It's not just, hey, what's the mechanism of action of lidocaine, right? Some of these questions where I always tell students, if the question doesn't start with an X-aged person who has this, you got to think it's going to ask phys or pharm or something that's not like a diagnosis, right? So this might have been, so it's not just simply, so you have to do kind of a couple steps before you can get to the answer. So they're numbing the nerve to decrease carotid sinus manipulation. And I would say, okay, so if I'm manipulating the carotid sinus, that's going to be sending information from the nerve, and I'd have to know what that nerve is going to do. So we're going to talk about the baroreceptor. I have an answer choice B. I like that answer choice. Let's learn about the baroreceptor and then revisit the question. So I want to talk about some of the players in the game before I start talking about the game, right? So when I talk about baroreceptor reflexes, baro means pressure, right? So if you have a barometer, that's measuring the ambient, the atmospheric pressure. There are other ways that our body will regulate our autonomic nervous system. So pressure is one of them. And then chemical sense is another. Those are going to be chemoreceptors. I'm going to allude to them. I'm not going to distinctly cover them. This is going to be a little bit of teaching, a little bit less interactive than I normally do when I tutor, so I apologize. But I want to get through some of these terms, and I know that most people, if not all, do not love complicated neuroanatomy. I do, but most people don't. So when we talk about baroreceptors, I know a lot of people will be familiar with questions about cranial nerve 9 and 10. They feel like, I always get them mixed up. So we have cranial nerve 9, which is the glossopharyngeal nerve, which is only an afferent limb in the baroreceptor reflex. And then we have cranial nerve 10, the vagus nerve, which could be an afferent or an efferent limb in the baroreceptor reflex, meaning that it could deliver information and transmit information back down. We also have the carotid sinus, the carotid body in the aortic arch. So I am a horrible artist, and that is just a cornerstone of me being a tutor. But if I talk about the aortic arch, right, and then let's say I send a carotid, and then I have a bifurcation of the carotid into the internal and external carotid. The carotid body lives in the space, I would say, like above the Y, right? So the carotid body lives right there. The carotid sinus is a dilation of the internal carotid artery just after the bifurcation. The carotid body tends to be more chemoreceptor oriented and will not be discussing it as much. The carotid sinus is baroreceptor oriented, and I'll be talking about for the most part. The aortic arch also has both. So when I talk about chemoreceptors, right, that would mean that my heart rate and blood pressure would change in response to the pH of my blood, the PO2 of my blood, the PCO2 of my blood. When I talk about baroreceptors, the aorta, how stretched it is, would change my heart rate, would change my blood pressure, would change my underlying neurology and my neurohormonal effect on this. All of these are going to move and effectively end up in the nucleus solitarius of the medulla, right? So these are in the lateral medulla. So again, I'm going to use a thinner marker, but people don't. So cross-sectional anatomy of the brainstem, medulla, sometimes like I always think of it as like kind of the Batman space. That's not even, I'm sorry, right? And you have the medial and the lateral medulla, right? And again, if you haven't done neurology, don't worry about it, but as much 9 and 10 are going to be lateral nuclei of the medulla, right? So all of the vagal and nuclei here, including the nucleus solitarius, they're over on the side. That's all you need to know about them. They're over on the side. And these nuclei are involved in taste, cardiovascular, respiratory, and gastrointestinal control. They're incredibly important, right? They control your breathing and all of these things that we're going to talk about. Kind of a mnemonic for this, like sometimes you'll see it written as the nucleus tractus solitarius. I don't know that you necessarily need a mnemonic for this, but it also helps me remember that it's cranial nerves 9, 10, and 7 for taste, the gustatory sense. So that also is somewhat, so this is split into a rostral and caudal nucleus. The rostral does taste, also called the gustatory nucleus. The caudal does all of the other stuff we're talking about. But nucleus
That is amazing.
Have you never heard that before?
I've never seen that.
Oh, well, I don't always find mnemonics super helpful because technically it could be like 9, 10, 9 trigeminal and 6, and like that wouldn't, but yeah, 9, 10, and 7.
I love it.
It's for nucleus tractus solitarius.
Yeah.
Great. All right. So I'm sorry that was boring. We have all of the players now. Let's talk about the true reflex. All right. So I'm going to talk about sensing increased arterial pressure, right? My heart is squeezing, my aorta is super full, and that's transmitting tons of increased pressure up my carotids. So at the level of the aortic arch, cranial nerve 10 will send information to the nucleus solitarius. Oh my goodness, I'm so full. Like I'm way too full. The heart is pumping too much blood into me, right? The carotid sinus will do the same. It will do it with the glossopharyngeal nerve. So there's a carotid sinus nerve that is a branch of the glossopharyngeal nerve. Both of them will project to the medulla, and then the medulla will learn from both of those and be like, oh, the aorta, you guys are too full. Like I can fix that. Send information back down the vagus nerve, right? Vagus nerve acting on the SA node to decrease the heart rate. Vagus nerve also, and kind of the idea of this increased parasympathetic outflow, decreased sympathetic outflow will lead to peripheral vasodilation. So we have decreased vascular tone, right? So both of those things should mediate the idea that these things are feeling too much pressure and too much swelling. My point is that you will almost always be tested about this one, right? You will always be tested about cranial nerve 9, because if I were writing a beautiful test question and I wanted to ask you about this pathway, would you really have to know anything? Like you could just guess cranial nerve 10 and it would be right, right? So they usually, and I think this is fair, when I say they, I mean people who write test questions, usually like to test situations in which there is a difference. And I think the fact that the afferent limb is 9 here and the efferent limb is 10 makes this a much more testable pathway. So that's how I remember that the carotid sinus is cranial nerve 9, aortic arch is cranial nerve 10. If you want to have like hardcore embryology ties, I also remember like the way that the aortic arch derivatives and like the whatever mandibular branchial cleft derivatives layer out. I know it's like 5, 7, 9, 10. Anyway. Sorry, Leah.
No, it's fine. It's just a lot of PTSD coming at me at once, you know?
Yeah, I know. I'm sorry. Okay, so that's enough. That's enough with baroreceptors. I think they're so cool. I mean, our body is amazing. The way it adjusts to stuff is amazing. Tying it across organ systems, right? So we talk a lot about physiology, and physiology can be intimidating. So obviously, we're going to talk about shock later too. So in cardiology, like hemorrhagic shock and how our body responds to shock or any sort. I want to talk about supraventricular tachycardias. I'm going to have a separate slide on those. within neurology itself, right? So I talk about autoregulation. So I'll talk about Cushing's triad. Does someone want to put in the chat what Cushing's triad is? Cushing, there's tons of stuff named after Cushing. Lots of Cushing eponyms. But
syndrome,
specifically within neurology, and I would say maybe someone who has increased ICP.
Nice.
Great. All right, Chris and Elizabeth, they filled both in, right? So in the setting of increased intracranial pressure, someone will then respond by being hypertensive, bradycardic, and having respiratory depression. I would agree. I like Shalisa's adaptation there. I think irregular breathing and maybe disordered breathing is a safer way rather than respiratory depression, which makes me think just low. And the reason that is because I think of it, increased ICP is going to clamp down on the vessels supplying the brain. So the brain is going to tell the heart, please send more blood my way. So the heart's going to say, sure, I'll do that. And it's going to clamp down the peripheral vasculature, leading to hypertension. And then the heart's going to react to that and say, that's too much blood pressure. I should slow my heart rate down. Then you get bradycardia. So now you see why this is a pathway, and we're getting miles and miles down from the original insult, which is ICP. Suma, to summarize, the triad is hypertension, bradycardia, and irregular respirations. The cause of the triad is increased intracranial pressure. Increased pressure, I think, causes the hypertension first, then the bradycardia, and then the effect on the respiratory centers in the medulla because of the ICP, I believe, account for the respiratory alterations. When we talk about autoregulation, there's cerebral there's renal autoregulation. Basically, that's the idea that at these kind of, right, so if I talk about these being blood pressures, so at a blood pressure of 0, peripherally, like my brain's going to feel a blood pressure of 0. As my blood pressure goes up, my brain's going to feel all of that. But then in this window here, despite increases in my systemic blood pressure, my brain is going to sense a common blood pressure. It tightly regulates how much it wants in there. That has to do with baroreceptors and chemoreceptors. I have Parkinson's with an exclamation point and a question mark because I love it. Part of the kind of the theory why patients with Parkinson's disease have so much like autonomic and orthostatic instability is because of abnormalities of their baroreceptor reflexes. In GI, we'll talk about Cushing's ulcers, right? So those are stress ulcers. Those have to do with massively increased vagal tone, right, to the stomach, right? So typically, remember the step 1, Cushing's ulcers are stress ulcers to the stomach, and then curling ulcers. What causes a curling ulcer? ICP, I would actually put in the cause of a Cushing ulcer. Kristen, good. Burns, yeah, so think curling iron. So curling ulcers are caused by curling iron. They cause burns, typically not in the stomach. They're typically in the duodenum. Suma, no need to say whoops. I will say things incorrectly all of the time, and Leah will fix me. I think saying I don't know is the most beautiful thing that we can do in medical training because it shows someone that there's an opportunity to teach us something. I love it. Understanding the effect of a vagotomy in someone who has horrible like peptic ulcer disease, and like how would severing the vagus nerve, right? So remembering that acetylcholine is a primary driver of the acid release. Leah is about to teach us all about RAAS. And then I know everyone loves the pharm questions about reflex bradycardia and tachycardia. So if I infuse phenylephrine, I have massive alpha-1 agonism peripherally, clamp down my peripheral vasculature. My heart then says, and my baroreceptors say, oh my goodness, your blood pressure is way too high. Turn the heart off a little bit. I have reflex bradycardia. Additionally, conversely, if I give an agent that widely pools my peripheral vasculature, my pressure goes down, I have a compensatory tachycardia, right? So always think about the primary insult to the pathway, and then if you know your pathways well, you follow them all the way down, and you can see how they're going to vastly affect the body. Any questions on baroreceptors? Everyone's ready for renin. Renin's the all-star of this. Renin, oh wait, no, I have another one, I'm sorry. Oh my God, wait, I said I was gonna talk about this because of, yeah, supraventricular tachycardia, because I think this is a cool point. So supraventricular tachycardia is exactly what it sounds. It's a word that we read and we don't know what it means. And Leah and I both were like, we have to teach this all the time. And you can have, like, there are multiple tachycardias, fast heart rates, that start above the ventricles, right? So above the AV node. Atrial fibrillation is technically a supraventricular tachycardia. Atrial flutter is a supraventricular tachycardia. And sinus tachycardia is a supraventricular tachycardia. This one, PSVT, paroxysmal supraventricular tachycardia, is the one that we normally think of when we just say SVT, right? So this is kind of the one of the four that like owns the name the most. This is the EKG, the way that it's normally helpful for me. This is incredibly fast. If I can see, this is like my cheat code for everyone. If you're taking more like step 2 or like even step 1 and EKGs scare you, if you can see the T wave and the P wave, but it still looks fast, that's probably sinus tachy. If you can just see one of them, they're so close together that they look merged, that's probably PSVT. This disease can affect young people. So young people with intermittent runs of tachycardia, I would think PSVT. Comes in and out, right? So all of a sudden someone's heart rate will just be 180 for no good reason, right? Nothing prompts it, just out of nowhere 180. What is the first line treatment for PSVT? Leah, you can help out. Vagal maneuvers, I love it.
Awesome. Yeah, I didn't have to. I will say this question is asked a lot, and it is always asked in the context of a patient comes to the ER, right? And they have a supraventricular tachycardia. What's the first thing you're going to do?
Right. So the correct answer is vagal maneuvers, right? Because if you think about it, a drug costs money. Asking someone to bear down and pretend like they're having a bowel movement costs no money, right? So vagal maneuvers are anything that we can do to our own physiology to prompt increased output through the vagus nerve, which should then decrease my heart rate and increase my AV nodal refractory period, right? So how can I turn the vagus nerve on? And I mentioned one of them. So I mentioned one of them. Okay, so here's my, I don't know if we have any step 2 people, and this was my question, and if we don't have any step 2 people or people who is Wayne, love it. Wayne, I'm putting you on this, I don't have to put you on the spot. Anyone, including Wayne, can answer. So what is my first line vagal maneuver in an adult, and what is my first line vagal maneuver in a child? Squatting is a good guess. It's not squatting. Valsalva in an adult, agreed. So the modified Valsalva maneuver, child, carotid sinus. All right, so good. So the modified Valsalva maneuver, right? So you have a patient pretend like they're going to bear down, and then you actually do a leg lift. That's the modified Valsalva. For a child, it's actually called the dive reflex. You put their face in a bucket of cold water. That's the first line vagal maneuver in a child. I think probably because it requires less. Second line treatment for PSVT in general is adenosine, the pharmacologic agent, right? Someone brought up a great point. I should stop talking, but there's so much good stuff to teach. Someone brought up carotid massage. I have a 75-year-old lady with hypertension, diabetes, and peripheral artery disease who presents in what I believe to be SVT. Why would I not do carotid massage in that person, and what could I potentially cause in her, Leah?
So I would not want you to do that because, good, syncope, you are going to cause syncope, but because of the diabetes and hypertension, I'm also thinking atherosclerosis. And I'm thinking carotid stenosis, and you're going to dislodge. Yeah, good, awesome. So someone said embolism. You're going to dislodge some plaque and send it up north. Great.
Yeah, so carotid sinus massage has fallen out of favor as a vagal maneuver. 1, super unreliable. 2, risk of atheroembolic events from atherosclerotic plaque, absolutely. So whether that be TIA or stroke in the anterior circulation, right, which would be AC or MCA territories. Amana had brought up an oversensitive carotid. That's kind of the other side of the coin, which is carotid sinus, like hypersensitivity. Those are the people that have carotid sinus events when they shave or they wear a turtleneck or they turn their head too much. Their carotid sinus is so sensitive that things like turning their head increases pressure and causes them to pass out. Shaving, pass out. Wearing a turtleneck, pass out. So tons of great correlations here. But I did want to address.
It's funny because that's actually how they present it, right? They literally say someone's putting a tie on and this happens, or yeah.
Yeah. Okay. Is it still in step one? Saw doesn't answer. Okay, I agree. Like if it's the only one there, if the answer is like carotid massage versus like digoxin and all the other like meds, then I would pick carotid massage. If I'm going to say in the umbrella of vagal maneuvers, what's the most preferred and the least preferred, carotid massage is going to fall on the least preferred options. I think if I were in the middle of the woods and I had no access to medicines and I tried vagal maneuvers, I tried a dive reflex, I tried, all of these things, and my last line was carotid massage, I would do it because I think the risk of atheroembolism is probably quite low, but it's enough of a risk to avoid it. Iris, I don't think it would cause a clot, but if I had a fragile plaque there in the artery, so like inside my hand like that, and you think I'm like vigorously rubbing it on the outside and it dislodged on the inside, it would flick up into the brain.
So just to sort of reiterate that point, Michael, this patient that we were talking about in the context of this vignette was actually getting a carotid endarterectomy, which you guys are going to most likely see on your surgery rotation. And they're endarterectomizing the artery, which means they're taking plaque out. So that's what this surgery is. This patient is getting a surgery to take plaque out, and that plaque can dislodge and go to the brain. And that's why we take it out, just to sort of drive that point home.
Yeah, great. And I'm glad you caused me to revisit it because I me, I went on a tangent. So yes, the answer here is rapid bradycardia, right? Trying to prevent the rapid bradycardia from overstimulation of the carotid nerve.
And also, you guys, this was a question I got asked in a surgery. So this is real. This happens, and people ask about it.
Oh yeah, like my first week of internship, I had a lady come in SVT, and I vagaled her out of it. Like this is real life.
All right, y'all ready for RAAS? Okay, so this is quite the stem. We're gonna move through it in the most simplistic manner possible. So y'all hang in there with me and try to answer my questions so we can make it more fun. So we have a 68-year-old man. He comes to the ED. He's got a 2-week history of progressive shortness of breath. His symptoms started 2 weeks ago. They worsened, so now he even has a hard time catching his breath at rest. His past medical history is significant for hypertension, and the patient consumes 2 to 3 alcoholic beverages on the weekend. He smoked a lot. He takes no medications. Not so great. Vitals are within normal limits. So he's got an elevated blood pressure, elevated heart rate, elevated respiratory rate, so not within normal limits. His oxygen saturation is low. He's got an S3 with distant heart sounds, positive JVD, 3+ pitting edema. Can anybody tell me what all of these things are sort of adding up to? The shortness of breath that's getting worse, good heart failure. This guy has heart failure. CHF, his heart's not actually pumping his blood forward. Now, can we determine whether this is right or left heart? We can say that it's definitely affecting the right heart because we have a positive JVD. We don't necessarily know because we don't know the status of his lungs. So if we know he's 93% on room air. So it could be left heart causing right heart failure, right? But regardless, this guy has CHF, right? So something that takes a while to sort of wrap your head around in terms of CHF is that even though your volume, you have signs of volume overload on physical exam, you actually your body is sensing that you're hypoperfused because you're not pushing blood forward, right? And because of this, your renin-angiotensin-aldosterone system is activated. And this is sort of a a perfect storm. So the renin-angiotensin system is activated. That increases your hypertension, which can exacerbate all of these issues. So this vignette is beautiful, full of a lot of information. We don't necessarily need it, right? So what we need, I often have students rephrase questions. So tell me, rephrase this question in a way that's as simple as you possibly can make it. And for this one, what we would rephrase it to say is, which of the following is likely to be decreased in a patient with CHF or with the CHF exacerbation? And because we know the renin-angiotensin-aldosterone pathway is activated, we know that they're going to be affected. Also, we're taking a look at the answer choices and seeing that they're all sort of targeting that pathway. So RAAS is complicated. I want to walk through the next few slides. Does anybody want to take a guess at the answer just so that we can go through it? So someone said E, potassium excretion in the collecting tubules, and someone said C. Someone else said C. Good. So the important part here is asking which is decreased in this patient. So pay attention to what decreases and not what increases. We know angiotensinogen increases, right? We're increasing ACE. We know that contraction of smooth muscle increases because we're vasoconstricting. When we vasoconstrict, the diameter decreases. So C is our answer here. That's okay, Kai. We all have it. D, sodium hydrogen exchange actually increases. We'll talk about that later. And our potassium excretion also increases. So make sure to target that decrease and reword your questions. If you can take the time to sit down and say, what is the simplest way I can ask this question? It'll really help you wrap your head around taking like a really complicated vignette and narrowing it down. So let's talk about RAAS. This is a very complicated pathway. What I want you to do is, next slide, Michael.
Cancel all images that look like that.
Simplify it. So I will say first aid has a really great pathway, but remember when I was talking to you guys about using multiple methods of memorization? Write it down, draw it out, act it out, like literally rub your carotid sinus and ask yourself what's gonna happen. Maybe don't rub it too much, right, Michael? Just rub it a little bit.
Don't do bilateral, because then you...
No, not bilateral, right. So simplify it in multiple different ways. I really like the organ system specific. So asking myself, what does RAAS affect? It affects two places in the vasculature. It causes generalized vasoconstriction. It also causes efferent arterial constriction. So vasoconstriction overall, but one of them is very specific at the efferent arterial. It affects three types of renal cells. One in the PCT, two in the collecting tubule, the principal and alpha in the collecting tubule, and it affects the brain, causes thirst in the hypothalamus. So if you really wanted to look at RAAS holistically, you could say it affects the vasculature, it affects the kidney, it affects the brain. Now, once you guys get good at this, and somebody might have already noticed this, I left the adrenal cortex out. We know that aldosterone comes through the adrenal cortex, right? So you reorganize this. I challenge you guys to go, after you finish this webinar, find some renin-angiotensin-aldosterone system question and reorganize this how it makes the most sense to you. This is how it makes the most sense to me. So Michael, if you want to go to the next one. This is just driving the point home. This is a little bit of a different way. Experiment, you guys. Try different ways of looking at things. So this is my way of looking at it in a flow sheet type format. So go from the liver to the DCT, the macula densa, senses an increase or decrease in sodium or pressure, and it activates the lungs and the kidneys using renin, angiotensin, aldosterone, and then those things go out to my three organ systems I talked about, the vasculature, the kidney, and the brain, and then I sort of go from there and ask what's affected within these, what sort of interacts within them, and then Michael, if you go to the next one. And then what's the actual final effect? So I would say the yellow is the most complicated, obviously, knowing this direct effect. The pink-red color is the second most complicated, but often what they'll ask you about is these large organ systems. So where does potassium excretion increase? Well, you have to know it's somewhere in the kidney to choose the answer full cell. So knowing these big picture items and being able to take a question, narrow the vignette down, and decide based on your narrowing of vignette what the big picture answer is can be really helpful and can get you a lot of these questions right and help you understand it like big picture. All right.
All right.
Oh, and that was it for me. So if anybody has any questions, send them in the chat, but otherwise Michael's going to talk about shock.
We'll pause for questions on renin-angiotensin system.
Sure.
All right. We've talked about a couple things. I don't know if I can maybe link vitamin D to it, but we've talked now about baroreceptors and renin-angiotensin system. So now we have to talk about like when everything goes wrong, which is like the state of shock in the body. So Leah loves this table. I don't particularly like tables, right? Because I don't like memorizing tables without the story behind them. Like that just, I don't know. I'm as you can tell, I like to talk and I like the story behind it. And I don't know, it just doesn't do it for me. So I think if you can look at this table and memorize it and everything makes sense to you, like good for you. But I also think it's hard too, that if someone like asked you a couple months down the line to like explain something, I think, okay, here's the way that if I can explain something to let's say an elderly family member who has no medical background, then I understand it. Right? And not like, hypovolemic shock is a state of this. Like if I can explain it so that they understand it, right? I use lots of analogies, lots of things like that, then I feel like I understand it. So this table, if you can get that from tables like this, then study this way. If not, I'm going to offer you a different way to learn shock. But before we do that, I need your help to tell me, what is your definition of shock? We have to define it.
I love this audience. They're like actually really excited to learn things a different way.
Low blood pressure, high pulse. Can you have shock with a low pulse? Yes, you can. Okay, I see hypoperfusion to organs. I see tissue damage from lack of O2. I like both of those. Anyone have any imbalance in hemostasis? Or do I have to have a clotting disorder to be in shock? These are I'm glad, great, right? So when I ask these kind of more Socratic questions out loud, it's to help people like refine a definition. Amazing. Shalissa, I think that's a perfect, when I basically can't meet the metabolic demands of the body. For one reason or another, I cannot adequately meet the metabolic demands of my peripheral tissues. So I think that's taking kind of the best parts of everyone's definition. I love crowdsourcing for a definition. I think we've arrived at a really good definition for shock. The next, now, of course, the previous slide kind of is understanding the 4 types of shock, right? So I think you'll see lots of different, so what I encourage you to do is have 4 big buckets that shock can fall in, and there are sub buckets in those larger buckets, right? So if we could just go through the first, I want to think about hypovolemic shock. The second, I want to think about cardiogenic shock. Third, I want to think about distributive shock. And then fourth, I want to think about obstructive shock, right? And people are going to be like, well, what about anaphylactic? And what about septic? And what about hemorrhagic? And what about all those things? Those are all going to fall under the big buckets, right? So I think if you use those 4 big buckets, then you're going to be fine from there. Now, my last question is, what lab test do I use clinically to determine how shocky someone is? Great. So a lactate, right? So a lactate is going to be my measure of how adequately I'm perfusing my end organs, which was my definition of shock, saying that I'm inadequately doing that, right? So I would say a lactate is a very good central measure of how shocky someone is. Awesome. So I want to use a formula, right? And I know we typically retreat away from formulas in the rapid review section of our textbooks to learn. And I want to use this kind of mean arterial pressure, right, is equal to cardiac output times systemic vascular resistance, right? You could have this as TPR, total peripheral resistance. You could have this kind of map. You could say this is the perfusing pressure. Basically what we're saying in our definition of shock is that this is bad, this is low, right? Our ability to perfuse is low, right? So someone used low blood pressure as a definition for shock. I like it. Think it could be a little more, right? So next I want to expand and say, what's the formula for cardiac output? How can I make that even more specific? There's a couple. Cardiac output is equal to, amazing, Zoe, I love it. Not blood pressure, Suma. Blood pressure is going to be kind of included in some of the other things here. Heart rate times stroke volume, right? So how full is my heart and how much does it squeeze out? And how many times a minute does that do that, right? Because cardiac output is the amount of blood delivered to tissue in my body per minute, right? It's liters per minute typically. So now that I have this kind of nice way of thinking about, right, shock, I know that this is going to be abnormal. And I've talked about my 4 buckets of shock, right? Actually, all of them are relatively well explained by some variable in this equation. So let's talk about distributive shock. What is the primary abnormality of distributive shock? Vasodilation, excellent. Good, so my SVR is low. Awesome, perfect, decreased SVR. Causes of distributive shock, sepsis, anaphylaxis, neurogenic, all of them are linked by low SVR. No need to memorize anything further from there. Okay? Hypovolemic shock. Which variable do we kind of put that under? Yeah, low stroke volume, low preload, exactly, totally. Right? Cardiogenic shock and obstructive shock are very similar. I would caution using heart rate, right? But yeah, just low cardiac output together, right? Both of them. So cardiogenic shock is low cardiac output because the heart is either limited in its systolic or diastolic function. Just obstructive shock is the output from the heart is either blocked by reasons of the heart or reasons of the great vessels. That's it. So no matter what, these variables account for my definition of shock. Now moving forward to the next thing we would see in the table, which is how does the patient look? How do they feel? Anything that's limiting cardiac output, right? So our hypovolemic, our cardiogenic, and our obstructive shock, the patient is going to be cold and clammy. Anything that's mediated by low SVR, where things are pooling out in the peripheral vasculature, those patients are going to be warm and dry. So I like this because that's all I have to remember. And that already fills in huge, huge columns of the table. The next thing we talk about the table is if this is the primary insult, this is the compensatory mechanism, right? If I have sepsis and I have widespread peripheral vasodilation from gram-negative bacteremia and LPS endotoxin and all of those things, my response is going to be tachycardia. If I have whatever it might be, my response might change, right? So rather than memorizing the table, primary insult, what does the body do from there? So I want to add a little bit to the table, right? Beef the table up a little bit from previously and just walk through it now. Does this make sense? Like, I think I like this. I think I can answer most questions on shock and understand most of the up-down arrows in shock on this equation based off of a table. Can I read? A little stuck on low SVR equals warm and dry. Great. Okay, so I'm going to put my hands like this, right? And this is my cross-section of my peripheral vasculature. If I'm clamped down, right, I have very little blood going out to my fingers, right? So if I go outside on a cold day, I live in San Francisco, it's windy and cold, and my fingers get white, right, or blue, because all of the vasculature in my hands have clamped down because they're trying to preserve blood to warm my core. If I am, sweating, running, and I'm flushed, right, all of the vasculature is opening up. Those blood vessels are closer to my skin, and my face will be red. If you're in septic shock, everything is opening up. All of the blood, I want you to think, is closer to the skin, so the patient will feel very warm, even though they have low blood pressure, right? So that's a challenging standpoint because people think, oh, they're cold, they're not perfusing. True, but also in septic shock, they're not perfusing, but they're warm. So this is, I think, a really helpful primary and distinguishing factor clinically in real life and also in questions. All of these are linked by a common low lactate. So to each of your 4 buckets fall into one of those 2. Yes. So I think I could probably have fixed this slide. So let's do hypovolemic, cardiogenic, and obstructive. And over here, let's do distributive. I will update these slides so that they are better. But thank you, Kyle. That's a helpful. All right, so those are going to carry forward to the next one. But okay, so now applying those to this table, like you can walk through things. So the primary insult, there's like lots of different types of hypovolemic shock, right? So hemorrhage, obviously, if I'm GI bleeding, if I'm hit by a car and I'm bleeding from, I have a liver laceration or spleen laceration. Dehydration, I would say normally in the setting of diarrhea is something that can cause someone to be so profoundly dehydrated that they go into hypovolemic shock. Also remember burns. So burns technically cause you to lose insensibly through your skin. That can cause a hypovolemic shock. The primary insult is going to be a vast reduction in my preload. The response of my body is going to be to try and clamp down my vessels to improve my perfusion pressure. And my cardiac output is going to suffer because of my low preload. My tissues are going to be poorly perfused here, and my skin is going to be cold. Cardiogenic, I want to kind of point everyone's attention. Cardiogenic and obstructive shock are physiologically identical, right? There's blood that's not getting out of the cardiac system to the body. They are physiologically identical. The reason we separate them is from treatment standpoints, right? So things that affect the cardiac system, right? So systolic or diastolic function, right? MI, heart failure, arrhythmia. I'm going to take PE out of there. Those are going to cause cardiogenic shock, right? So primary insult being low cardiac output, response of my body to clamp down. Preload may or may not be an issue. Tissue perfusion is low, I'm cold. Obstructive shock, I have a huge PE that's limiting blood from getting from my right ventricle, right, anywhere else. Low left ventricular preload, low output to the body, shock. I have massive and serious aortic stenosis, limiting anything from leaving the heart. I have a huge aortic dissection, limiting anything from leaving the heart. I have a tension pneumothorax, clamping down on my IVC, preventing anything from getting to the heart. Any of those things, obstructive shock. Cardiac tamponades in red, because I want to teach it separately. Distributive shock bothers people because there's multiple different types and they do different things. And Leah and I had a very healthy disagreement about this earlier, but I think it's great, right? So I do think that neurogenic shock confuses people the most. What I do want to talk about that I think is helpful is the relative incidence of each type of shock. And Leah, I'm actually going to throw this question to you. Which type of shock is the most common? I know. If you just have to guess, based on like being a fourth year med student, like which one do you see the most?
I mean, I want to do vascular, so I see septic shock all the time.
Totally.
Infections all over the place. So I would say septic shock, distributive.
Distributive shock accounts for 60% of cases of shock.
Yes.
Right? Next most common would be hypovolemic. Last number I was taught / researched is 27%. Cardiogenic shock, 12%.
Kind of surprising.
Yeah, so I think the point is that these conditions very rarely get to the point where they cause clinical shock. And it's also very hard to characterize shock in the setting of those conditions. But I would say distributive being the most common. And then the 3 buckets of distributive being so different, right? So sepsis being mediated by bacteria, anaphylactic shock being mediated by histamine, right? Sort of a cool teaching point, random trivia fact that may or may not matter. If you have anaphylactic shock, that is an IgE histamine mediated vasodilation. If you have anaphylactoid shock, that is like a somewhat of immune, it's an IgE independent allergy that causes shock. So contrast causing shock tends to be anaphylactoid, not anaphylactic, whatever. And then neurogenic, right? Neurogenic does not only include spinal cord abnormalities. It can also include things that happen in the brain. So there is spinal cord shock and there's it's a bucket underneath neurogenic shock. So you can see how the layers of these can be so confusing, which is why I want all of people who are like more primary learners, right? If this is the first time you're learning shock and what I'm saying in the last 15 seconds has you sitting there like, oh my goodness, I don't know anything, that's okay, right? Know the 4 buckets, know the equation that I taught, know how to separate them, and you're golden. You know more about shock than most people, right? These tiny little details you add on with time. I want you to have a strong foundation, and then I want you to add layers as we go. Sepsis and anaphylactic shock tend to, right, their primary insult and all distributive shock is to massively decrease SVR. There's a compensatory increase in cardiac output, and because blood is pooling so much in the periphery, you have low preload, right? Most of that blood doesn't make it back to the heart. So eventually it can limit cardiac output, which is why I don't really like putting arrows under cardiac output here. Additionally, right, I think, so Leah and I had a discussion about whether or not tissue perfusion is increased. I think the fact that these are up is kind of saying like, oh, it's warm and dry. Like that's why, because there's blood there, but the blood's not technically perfusing. So that's why you have an elevated lactate. You will be tested when you get into like step 2, and I don't want to, is about how the mixed venous oxygen concentration, right? So normally, like none of these types of shock, like this doesn't affect how your body extracts oxygen from blood. Septic shock does. So for septic shock causes a high MVO2, whereas everything else is a very normal. So the ability of peripheral tissues to extract oxygen from blood is impaired. So by the time blood gets back into the mixed venous system, right, to the vena cava from central monitoring, it's higher than it should be because you didn't pull as much blood as you should have. Does that make sense? I've seen questions asking about MVO2 in UWorld. I have too. I think it's good to know about. I think in patients who are in the, so mixed venous oxygen saturation should be increased in sepsis. They do love that. It's clinically important. Sort of like a little caveat, right? You'll also see, I didn't want to use all these variables because I think it's confusing. You'll see things like CVP, the central venous pressure. So when you think about CVP, think about a catheter being in someone's superior vena cava. How big is it, right? So how dilated is it? How full of blood is it? In hypovolemic shock, not full, right? That's kind of the definition. It's very empty. Cardiogenic shock, the heart is not pumping blood anywhere. So it's backing up. This CVP is going to be super high. Obstructive shock, like I said, same physiology, super high. Distributive shock, that blood is all spread out in other places in the body, it will be low. I encourage you to not memorize all the variables as high or low, and try and do what I'm doing here and talk through the physiology in your head and get good at it so that when you come across a new variable, you can apply it to the situation. All right. And then in distributive, this gets kind of, so neurogenic, right? So one of the primary insults in neurogenic shock is that you lose catecholamines. So even though the primary insult is SVR and you should have a compensatory tachycardia, you don't have the ability. So you become hypotensive and bradycardic, which is a bad combination. No preload, no perfusion, warm and dry, early, not as much, but again, harder to think about. Okay, I wanted to quickly talk about this, and this will be our last point. So if you're like, oh, clinging and almost going to bed, then I apologize. But this is also something that gets tested a lot. And I think I love to teach. It's one of my favorite things to teach. So I mentioned cardiac tamponade as a cause of what type of shock again? Obstructive. Awesome. All right, great. So I want you to recognize that cardiac tamponade is a clinical diagnosis, right? It's not like I do an x-ray and I'm like, oh, that x-ray shows me cardiac tamponade. Like it's a description of someone's physiology. So, and then Pulsus Paradoxus, I defined it here. So it's an exaggerated fall in our systolic blood pressure during inspiration of greater than 10. This is a mechanism that is beautiful and I think is worth explaining so that you understand, right? So I'm going to draw, again, terrible artist. That's a heart. There's 4 chambers to the heart. There's some valves there, but effectively I have a right atrium, I have a right ventricle, a left ventricle, you get it. All right, so in cardiac tamponade, right? So can someone in the chat, or Leah, if you want to just go ahead and tell me what happens in cardiac tamponade. So if I have normal pericardium here in purple, what's happening in tamponade?
Something gets in there.
Something gets in there.
Yeah, blood. It can be blood. It can be any type of fluid.
Anything. It can be normal fluid. It can be blood.
Yeah.
So effectively what happens, I agree with you, is that the pericardium is full of stuff, right? And the pericardium is kind of a fixed tissue. It can slowly expand, but if it gets filled really quickly, so you'll learn, like, if it gets filled with like 100 cc's quickly, then that's too much. But over time, and it can accumulate, like, I don't know, like a liter or two. Like, it can get huge.
Mm-hmm.
So the pericardium gets so full, and let's say this pericardium cannot stretch anymore. This purple pericardium has reached its limit. So when I inspire, right, I take a deep breath. I have negative intrathoracic pressure, which should, in theory, right, things move from areas of high pressure to areas of low pressure. So normally, in my venous system, right, so if this is my IVC over to the side, negative intrathoracic pressure should drive tons and tons of blood into my IVC. That blood should go into my RA, no problem. It'll go from my RA to my RV, no problem, right? There's no issue there. But when my heart tries to expand to account for all of the blood, it can't, right? It meets this substance outside of it that it's not used to, right? This purple is stiff. It's not allowing the heart to expand. So this RV, if you think about it, it got 100 cc's of blood when it only bargained for 50. And it can't go out. So the only direction that it can go is actually by stealing room from the left ventricle. So it will bend the interventricular septum, this red line here that I have in the middle, and it will steal space from the left ventricle, which wouldn't be a problem if the left ventricle could go anywhere, but it can't. So the left ventricle now, in total, has way, way, way less space than it wants to, right? That's much, much less space in the left ventricle. So when the left ventricle tries to eject blood to the body, which we would then feel as a pulse or blood pressure, it's going to be way, way lower. So in states of cardiac tamponade, or in tamponade physiology, we're going to generate pulsus paradoxus, right? So a low pulse. Does that make sense?
Love it. It's awesome.
All right.
I don't know what you're talking about. Bad artist. These are all great pictures. I mean,
they're just ugly. I wish they were.
No, they're great. They're great.
All right, Leah, one more question for you, and then I'll leave you alone. Is I've seen pulsus paradoxus in one other condition other than cardiac tamponade. I've been tested on it. What is it? We might have help in the chat.
So asthma is a big one that they like to, oh yeah, asthma, nice. All right, thanks guys. Asthma, obstructive sleep apnea is another one that they really like to test it on. There's some mnemonic in first aid that's actually pretty helpful. But I know it has asthma and it has OSA, has COPD. Are we missing one?
I don't think so. I actually really just think of cardiac tamponade and COPD.
I know obstructive sleep apnea is one of them.
Cool.
And I sort of link it into asthma. I know that's not necessarily, but you've got like obstruction, you know, in the respiratory system. So I sort of link those together. Lots of
great guesses coming through the chat. I'm gonna.
Crew. That's the other one. That's the one that. So yeah. Sorry. Okay. Whoever said that. Thank you.
Interesting. I didn't know that. I can probably link them all together as anything that's causing hyperventilation, right? So severe expansion of the lungs can cause pulsus paradoxus. And the reason that is during inspiration, if I fill my lungs and I have limited ability to remove that volume, similarly in the pulmonary vasculature, and I think in particular the pulmonary veins, expanded lungs are going to compress them and limit my left atrial and left ventricular filling. So any condition, asthma, COPD, I did not know severe croup, thank you everyone for teaching me, that can cause hyperinflated lungs will lead to pulsus paradoxus physiology. Awesome. I love that. Collective learning. ENT does rock. ENT saves everyone all the time. Thank you, ENT.
I could never get used to the secretion. So props to you. All right. This is the best part of the webinar is coming up. You guys hang in there with us. So we're going to talk a little bit about MST, and then we're going to open the floor to any questions. So MST, it's us. It's me and Michael. It's all of these tutors and all of these attendings and all of these incredible people who come together to help you guys. So basically, you're going to get a custom study schedule, and this is sometimes one of the most important things to students because it sort of helps them understand what to do next and where to go next. It's tailored to you, your goals, your strengths, your weaknesses. It is probably the most dynamic part of our interaction because it's going to constantly change. We've got these adaptive tutoring sessions, so it's exactly what you guys experience here tonight, except you get it every week and you get it personalized and one-on-one. So we're asking you guys these questions directly, you're sending them right back at us and that sort of thing. There's regular communications between sessions. So this is one of the biggest, I think, perks of being an MST student is that you have access to us through our phone number, our text message, our email, any way you can get a hold of us, it's available to you and we are available to you. So I have students sending me pictures of questions they don't understand. I have them sending me pictures of questions that they didn't understand last week that we talked about and they get now. And it's so fun to get these because I feel like it's really directly impacting people and directly impacting their success. And they feel comfortable enough to share these things with me. You can also send updates on, you know, I want to talk about this next time we talk. I keep missing questions on this. You get accountability, which is huge. We all know that med school is hard. You get mentorship, you get support and guidance. We also have these one-time planning sessions that are available, and we have RAAS consulting and residency interview coaching. I know Michael crushed interviews last year and has learned a lot from his experience. And there are so many more tutors who have learned like similar amounts, and they have a lot to share with you guys. So anyway, that's our pitch. We really enjoy what we do. We really enjoy teaching you guys. And my relationship with students it goes beyond being a tutor. It goes into, you know, we talk about a lot of things. We go mentorship. It's a good time. And I know some of you guys mentioned getting PowerPoints. So every PowerPoint that we share when we're tutoring is y'all's. So it's something that I give to all my students, and they use them outside of our sessions all the time too. So anything else, Michael? And if anybody has any questions, the Q&A is about to start, so you guys can start firing away while Michael has any closing remarks.
No, I think that you summed the sentiment of what we do beautifully, and I think that hopefully what we did over the last couple, you know what I mean, the last, hour and a half, like also is like different, like Leah and I are like, yeah, let's do a webinar on complicated physiology. We just, we're friends like that and we're tutors like that. So there's a question about if numbing the carotid sinus, does it decrease the afferent firing rate and therefore act like a hypovolemic state? That is such an interesting question.
I love it. I love the tying across different like potential pathologies.
So I would tell you that to be, and this is, we might be stretching a little farther into the things that I can like very clearly. So there are actually two different types of baroreceptors, and I would not be able to tell you off the top of my head whether or not they're both present. So there are sort of ones that are more chronic and like tonic, like all the time acting, and then there are dynamic acute changes in pressure. So I don't know that just inhibiting the carotid sinus would skew my whole body physiology so much. I do believe those tend to be more of the dynamic, and again, to make it even more neurologic, like the large alpha fibers, like the large myelinated, like sharp, big changes in pressure. More of the tonic blood pressure control tends to be in the aortic arch. And so even if I numbed the carotid sinus, I might lose the large swings that I would worry about with manipulation of the carotid body. but I wouldn't like totally zonk out my entire baroreceptor reflex to the point where my body thought there was no volume there. That's my interpretation of the question. That's not me like reaching a fact from the back of my mind saying like, yes, this is 100% true. I would wager that that's correct. Leah, do you have?
Yeah, I think this question is great because it sort of mixes cause and effect, which is sort of what happens in real life. But really what we're talking about is numbing the carotid sinus causes this decreased afferent firing. Also a hypovolemic state or a hypervolemic state will cause decreased afferent firing, right? So we're mixing cause and effect here, which is a great way to think about things. I don't necessarily, like Michael said, I don't know that that's 100% correct. It sounds right. But I like the idea. I like the curiosity. I think I like that we're mixing all of these. Yeah, it's nice.
So perfect. Like Leah did the better answer, which was not like pontificate on random stuff, which is be like, I do know that in settings of low volume, there's low firing of the carotid sinus, which leads to decreased parasympathetic outflow and therefore increased sympathetics and vasoconstriction. So that is the perfect.
I think I mixed that up. I think I said increase, but yeah. So someone asked, why did you say that in sepsis, the blood's not necessarily over-perfusing? What is the detail here? Michael, is that you?
That was like in that one chart, and I just wanted to clarify that like, I want you to think that there's tons of blood peripherally in sepsis, right? Because it's making people warm, and you can feel that there's lots of blood there, but it's not giving oxygen where it needs to correctly. So it's there, it's just not like really there.
So the tissue is not able to utilize it, right? The tissue is unable to use it because it's so infected. That's the way I like to think about it. Is there's so much infection going on and the body is so busy with all these bugs or these other issues that it can't actually use the oxygen that it's being given. And that's why someone asked about the MVOP. So the mixed venous oxygen tension is going to be high in septic shock because there's more oxygen returning to the heart because it's unused. And I think that's the UWorld question that someone was referring to earlier too. Because there's one that I mentioned students sending me pictures, and I get that picture a lot. The one of the UWorld question that has like, what is this and why does it exist? And I encourage you guys, I mentioned the big picture stuff earlier. Read mixed venous oxygen tension. It's my mixed venous. So where does all my blood in the venous system mix? It's my right atrium, right? So everything mixes together from the SVC and the IVC and the right atrium. That's where you're measuring mixed venous oxygen tension, right there at the top.
All right. Well, seeing no other questions, I wanted to thank everyone, especially Leah, but everyone here for their time tonight. This was a ton of fun. I learned a lot. I hope you did too. I would encourage you, right, to reach out at the kind of the numbers and the sites you see on the screen if you have further questions moving forward. But with that, I will wish everyone a really good night, and thanks.
You guys were awesome. Thank you for spending your night with us.
Oh, yeah.